at my age and with such a young family, it's easy to kind of have those thoughts about why me, and then the self-pity, and then that turns into a pretty slippery slope if you let it. So you definitely have to find ways to cope with that, for sure.
What is your full name?
Justin Taylor Hughes.
And where are you from, and where do you live?
I'm from San Antonio, Texas. We live just north of there in a small town called Bulverde, Texas.
And when were you first diagnosed with cancer?
I was in June of 2020. I was diagnosed through CT scan, June of 2020. I feel like I'm on the right path, absolutely. I feel like Immunocine is something that really anyone with a solid tumor cancer should do, because it's the only way I have found in all of this research that we've done to really effectively get your immune system in the fight. So I do feel like I'm on the right path. It's a matter of faith, really. You've got to believe that, you have to believe with all your heart that, you know, God's got control and He's going to make a way, even though you have no idea how He's going to make it. But, you know, when you embrace gratitude and give thanks and just trust with faith, and it really turns things around from a mental, spiritual perspective.
I'm Dr. Matthew Halpert. I have a doctorate in microbiology and immunology from the University of Alabama, Birmingham. Following that, I did a postdoc at Baylor College of Medicine in a lab focused on cancer immunotherapy, and in general, how the immune system works. Spending about 10 years there, I was also one of the co-founders of both Diakonos Oncology, which is a US-based venture pushing good science through FDA clinical trials, and also co-founded the Immunocine Cancer Center, which functions as a compassionate use cancer clinic in Cancun, Mexico. Specifically, Immunocine leverages novel, cutting-edge dendritic cell technology to re-educate and repower a patient's own immune system. Dendritic cells run the immune system. People have been trying to get them to work in the clinic for decades without much success. Based on discoveries we made in the Texas Medical Center, we have now advanced this to FDA-sanctioned clinical trials throughout the US, and then as a treatment offering in Cancun for patients that are not eligible for the clinical trials and don't have the time to wait.
I am Dr. Francisco Sago. I am a medical doctor. I have some other studies on regenerative medicine, and I am a member of the Immunocine team at Cancun.
I'm Dr. Eli Angulo. I'm part of Immunocine staff. I'm a medical doctor.
Okay, I'm Susana Hernandez Reyes. I am the cell therapy director of Immunocine.
Yes, of course. I'm Dr. Gregorio Viramontes. I'm an interventional radiologist. I'm also a radiologist. So I did medicine and then radiologist, and after that, interventional radiologist.
Hello, I am Dr. Luis Ferbeire. I been working as an oncology for about 30 years.
For the 5 years that I practiced prior getting to the Immunocine team, I worked as a medical doctor on the tourism medical field and regenerative medicine as well. And I got just to have the chance to meet a lot of people from the entire world, all parts of the world. I used to live in Cozumel, so that gave me a chance to attend a lot of different patients there.
It was very rewarding what I heard about Immunocine, and I started to research and to know the specialty that they have, the contact with the patients, that they do the follow-up, that this is not for everybody. That's something that I realized that it was something that I wanted to do, something that it's not for the financial like a lot of other companies, and this is more for the patients and to help people.
The science is real. It's not a fairy tale or like something that may work, or it's basic science or very basic science. It's something that can already be translated to human beings. I think we've all met someone with cancer or know someone that had cancer. And it's, in my case, it was my grandfather. I was very close to him, and I would have loved that he would have this option for treatment as well.
Once the IDCT or the vaccine is done, we apply 3 times every 2 weeks, starting 1 week after the central line placement. The idea is to deliver the shot near to the lymph node. I always plan in this according with the lymphatic drain. So my idea is to get the lymphatic drain going into the area, the nearest area of the main tumor. Sometimes we split the doses in different places. So this part is super personalized for the patient. And as I try to explain to the patient, this is like the these pictures that were in the Wild West, you know. Have you seen this guy? So, but with the little pieces, you know, the dendritic cells has a mustache, green eyes, yellow hair, and then the immune system will be able to detect an abnormal cell or cancer cells. The lymph node is the house of the T cells, so that's what we want to get in contact. The dendritic cells will share the information with the lymphocytes, the T cells. When the team shared with us that the patient is doing great, that are having a good response to the treatment, that an improvement, when they return, that's the most rewarding by far is when the patient came back and we can see the patient to the face and say, thank you, that paid everything.
That's perfect.
As oncologists, we are more used to work with surgery, radiation, and chemotherapy. That's the standard. But cell therapy in general, dendritic cells, natural killer cells, T cells therapy, all these kind of cell therapies are going to be the future in oncology, in cancer treatment, because surgery, radiation, and chemotherapy usually causes mutilation, causes complications and side effects, and that's the price we have to pay. And sometimes it doesn't work in 100% of cases. We have to look for new choices, less toxic, more natural, and using your own immune system to fight cancer I think is the best approach as a natural way to fight the disease. The most rewarding part is patient that goes well. But in oncology, you have failures and you have succeeds, so that's how medicine works.
Using this novel dendritic cell platform, in which we use a patient's own tumor sample to effectively double load their own dendritic cells, which then optimizes and engages a corresponding immune system or immune attack, we have multiple clinical trials going on at institutions such as MD Anderson, Baylor College of Medicine, UT Health, Cooper Hospital, and several more are now coming online. We have completed a glioblastoma trial for which we received a fast track designation at the end of 2023 from the FDA. And we also recently won a Breakthrough in Cancer Award, which will help us lead to more clinical trials and exploration in our standard of care regulatory system. Beside that, we have our sister company, Immunocine, in Cancun, treating patients on a compassionate use basis that are good candidates for this treatment, meaning it would appear to be or likely to be safe, and there's a good faith belief of efficacy. Down there, we have treated over 15 different types of cancers broadly, and if you specify those a little more, we're over 25. We have seen a very good success level relative to the norm. We have an objective response rate of right around 94%, which indicates getting the immune system properly educated and activated in the first place. If you want any other positive results after that, you have to start somewhere, and you have to start with an activated and corrected immune system. So we're at about 94% there. Following that, about 70% of the patients we've treated have seen positive benefit, ranging from partial remission to stable disease to being disease-free. Obviously, those statistics fluctuate some as we take more patients or riskier patients, or patients reach new platforms after their treatment. But given the minimal side effect profile and the typically limited options that these patients are faced with, we're very proud of this early success rate and expect that it will increase as we continue.
In Immunocine, patients have to receive a consultation with the oncology specialist, that's me. And in this consultation, we have to check for the inclusion criteria. That means if the patient is ready to receive the treatment, or is there any contraindications to receive the treatment. That's the first part. If the patient is finally accepted to receive the treatment, we have to examine the patient. We have to a few questions to the patient to see if there is anything abnormal in the lab work, in the imaging, or we have to see if there is probable complications in the future during treatment, because this immunological treatment takes time to work. So we have to see if the patient have at least 3 to 4 months of a stable disease to give time for the treatment to work. If you have a patient that is rapidly progressing in cancer, is not a good candidate, because before his immune system start working, the cancer will beat him. That's the problem. And that's most of the work I do the clinical part, the criteria for the inclusion of patients in the protocol, and check for aging to avoid complications during treatment. And we usually get in touch with patients all the time to see how it's going. Patients go back to their countries, but we still are on WhatsApp, on email, checking the symptoms, the complication, or anything that comes up.
So what I'm doing in the lab is I'm getting the tissue, I'm getting the cells as well. With the tissue, we are isolating and amplifying the RNA. That means that we are getting the RNA from the tumor, so all the information that is being expressed by the tumor, we get it, and then we make several copies of it. So that when we have a very small sample, it's like we could get like a whole bigger tissue. We also get proteins from that sample. And with the cells, what we do is that we culture them in the lab. They are not differentiated in dendritic cells when we get them, but we are simulating them. So we are convincing them, kind of like influencer molecules. We are just convincing them of becoming a dendritic cell, like dendritic cell, dendritic cell. They listen to this for about 6 days. And by listen, I mean they are exposed to these molecules, convincing molecules. And after these 6 days, we are finally introducing the tumor RNA and the tumor proteins with the cells. So the cells get to know these molecules, these proteins, and then they get activated. So they are like, I'm a young dendritic cell, I don't know what I'm doing with my life. And now they get like this information of, okay, I already know what I have to detect, I already know what I have to look for, and I'm able to do it by day 7 of the culture. On day 7, we release the cells from the laboratory. We do all the sterility testing and everything that needs to be done for the product to be safe as well. And then we store them in the liquid nitrogen.
Once the patient came through the first filter, when they are prospective patients, the team shared with me all the studies, all the radiology reports, and I said if the patient is fit for the biopsy and if there is a safety profile to the patient came here and be treated. So I'm part of the approval team. Once the patient arrived, I'm the one who performed the biopsies in order to get the samples for the material so Susie can work and get the material, the RNA. And also I place the central line that is used for perform the apheresis to get the white cells.
I'm part of the medical evaluation. What I do is try to find to know about the history of the patients, the medical history, to see if they fit for the treatment. We need to evaluate with the oncologist, obviously, all the cases to see if they are the perfect time to treat the patients and if they are safe to be treated by us. And obviously to see if this is really for the patient.
As a physician, as an attending physician, prior getting a patient here or deciding that they are fit for having the Immunocine treatment, they are evaluated throughout our medical staff. Then we present those medical cases to our oncologist and all the medical team in order to know if it's safe enough for them to bring them, if they have, and if they are inside of our safety frame, to know that we have picked them or choose them, selected them on the right time, or they needed at first to end up some chemotherapy or some other radiotherapy, so we know at the right time for any one of them to bring them in and to have the best outcome regarding to our therapy. So then after when we know that they are fit for our treatment, we get in touch or in contact throughout a Zoom call, emails or phone calls to the patients, and we may best know when might be the best dates to set up all the scheduling to bring them in, and that's pretty much the first part of when we decide bringing patients here.
As an academic researcher and someone who's gone through the mainstream mechanism for earning a doctorate, school, more school, being trained in our classical systems, I'm a fan of clinical trials. I understand the reason for it. It is very hard to derive meaningful statistics without very well-controlled clinical trials in the way we do it. The world looks to United States medicine as a leader, and one of the reasons for that is because of this system we've set up for study. So we need to do the clinical trials, we need to get those statistics, we need to have that validation, and ultimately get this approved so that it can reach widespread mass appeal. With that said, this is just biology. Patients that have cancer, in many ways, the underlying or one of the underlying causes is immune system malfunction, immune ignorance. Why didn't their immune system protect them from this threat? It's worked the rest of their life. It's protected people from, the viruses and bacteria and parasites and even other cancers. And for some reason here it has failed. And the way we've gone about fixing that is purely physiological. We don't have some unique or crazy toxin or drug. That isn't what we're doing. We take a patient's own tumor, We break it down to its components, its genetic code, everything that cancer is and could be. We break it down to its protein library, everything that it's presenting. We take the patient's own monocytic precursors out of their blood. We differentiate them into dendritic cells. This is the patient's dendritic cells now. We reintroduce the dendritic cells to the cancer in this very specialized way. This is the way all of our peer-reviewed publications are on, all of our patents are on, all of our trials are on. You can't just use dendritic cells, you have to use them correctly. And then we reintroduce those cells back into the patient, your functional lymph nodes, and about 94% of the time, we do see their immune system engage and start fighting the cancer. The reason we created Immunocine was not to denigrate or say anything disparagingly against the trials, but not every patient is eligible for those trials. And certainly not every patient can wait for this FDA process to bear out. And given that this is just biology, that it is safe, that it doesn't remove any other treatment options for a cancer patient, and in fact only brings more options to the table, we felt ethically conflicted to withhold this treatment or this opportunity for patients just because they had the wrong kind of cancer and couldn't get in the trial. Nothing about this treatment is cancer specific. And so we wanted to find a way where we could legally and ethically and with all the right integrity offer this treatment to patients today who could benefit, who do understand it, and who do want to add that as a weapon against in the fight against their cancer. And so that is the basis of why we formed Immunocine today, to help the patients of today as we lead to helping more patients of tomorrow. The way we can offer this legally is in Cancun, Mexico. This is based on COFEPRIS certifications, which is the Mexican FDA, based on medical approval, protocol approval. We have a ISO 7 certified lab, all of the right doctors, contracts with all of the private full service hospitals in the area as needed. Basically, Cancun became a way for us to legally offer this today with the right quality control checks and balances in place so that we know we're doing what we need to do. Until this is approved by the FDA, it will be difficult to offer this safely and correctly in the United States. When a patient reaches out to us, whether by a referral or through our website, we'll very quickly get back in touch with them, usually with one of our patient coordinators. Our lead coordinator, Nicole Verico, has been with us for several years and is a phenomenal entry point into the Immunocine ecosystem and helps walk patients through that submission process and medical review. Once approved and a schedule is built, a patient will fly down to Cancun, and as soon as they are off the plane and out of the airport, Immunocine is there to help them. So we send a driver to the airport to pick up the patient and any subsequent friends and family coming to join the patient. We'll drive that patient to the hotel, and there are times, depending on when this is happening, that our medical team will be at the hotel to meet with the patient to answer any last-minute questions, make sure everything gets situated and settled. It's a travel day, so we don't want to put too much on the patient. The patient at this point, or even before this point, will be in touch with our Cancun coordinator, Robin Hoffman, who is local to Cancun, knows the area very well, and essentially serves as your private concierge in where to stay, if you have questions about where to eat or what to do, or setting up your transportation, the things that you need to be comfortable and following a schedule in Cancun. Robin's going to help oversee that. You will at some point then meet with our medical team. This could be Dr. Francisco Zago, Dr. Ellie Angelo, or Dr. Laura Bernardo. And they will be your case managing doctor, so to speak, while you're in Cancun. The person that will be maybe easiest and quickest to ask questions of, run things by, that's going to check on you frequently to make sure everything's okay. During that first week will be maybe the busiest week for the patient. We need to get baseline scans, baseline blood draws, baseline biopsy. That biopsy is where we get the tumor material that we need to educate your future immune response. Things like the scans and biopsy will be conducted by Dr. Gregorio Viramontes, who is our interventional radiologist. Also during that week, you will have a few other things as part of setting this up, including Neupogen injections for 3 to 5 days, which will get your white blood cell count up. And at the end of that, you will have an apheresis procedure in which it's about a 3 or 4 hour blood draw in which your red blood cells are put back into your body, but your white blood cells are taken by the team back to the lab. And so week 1 is just meeting with a lot of the doctors, getting a lot of baseline reads and making sure we have your tumor material and your white blood cells. In week 2, we are doing the heavy lifting in the lab. Susana Hernandez and the rest of the scientific team in the lab is working to make your dendritic cells the correct things with your tumor and make sure that we make your personalized vaccine, which will be ready to go at the end of the second week. At that point, so during week 2, patients very often just enjoy Cancun. A lot of good food, a lot of good beaches, not much else that you have to do at that point where your immune system is at work. It's just in the lab, not in your body at the moment. At the end of week 2, you'll have another blood draw. You will get a sign-off from our oncologist, Dr. Luis Ferber, who will make sure everything still looks good and that we're ready to go. You'll then get your dendritic cell injection. Again, this will be by Dr. Viramontes. And that injection will be ultrasound guided near functional lymph nodes, but still amounts to about a 10-minute outpatient procedure. Following that, you may or may not receive a little pegylated interferon alpha, which is just a synthetic molecule of a normal protein your body makes when needing to eliminate cells. And so we are just trying to foster the environment that your body should have already made in needing to get rid of this threat. You then have about 2 weeks off. We very often tell patients to go home for those 2 weeks. Again, we will handle that transportation to and from the airport. Your immune system is going to start ramping up for 12 to 14 days. Whether you're on the beach in Cancun or you're back at home working is somewhat irrelevant. This doesn't mean there aren't other healthy lifestyle choices you can make to foster a stronger immune system or a stronger immune response, but you do not need to be in Cancun for that. Injecting more dendritic cells during this first 12-day period would be largely wasteful as your immune system is already on the ramp up. As it starts to wane around the end of that 2-week period, which is now at the end of week 4 in total, that's when we have you back for a boost, which follows the exact same procedure of blood draw, oncological authorization, and injection. You then have 2 more weeks while your immune system has now ramped up to a theoretical plateau. This is just following immune kinetics. And at the end of that 2 weeks, which is now at the end of week 6 in total, you'll get your 3rd and final dendritic cell injection following the same protocol, though potentially with an additional scan and biopsy so we can collect more data at this point. If we have more dendritic cells for you, we store those long term. We cryopreserve them in liquid nitrogen as future boosts to be collaboratively determined if a patient needs those at some point. And then once the patient goes home, we continue to stay in touch with them. We have aftercare coordinators such as Penny Doherty and Patricia Moore who may reach out to you to continue to follow up, explore how you're doing, if you have any new symptoms, new questions, if there's any other treatments you are looking at doing. We try and keep up with your data, your scans, your blood work, and monitor responses with you. In a way, we become your entire concierge team that you can bounce off of as you move forward. If you feel you need more medical concierge help, we can offer that too. We have a couple of doctors, for example, Dr. Kate Barrett, who has joined Immunocine in an effort to provide more care to patients after Immunocine as they're looking at their next chapter. Because the goal, as we say, is not to show you how awesome Immunocine is, but to get you back to complete health. And whether that's just with us or with us plus some combination of another treatment is is not the main focus. The focus is to getting rid of the cancer and moving on with life, and we value that as a very high priority in the Immunocine mission statement.
I came back after I did the chemo for a booster of IDCT. I elected to have a booster round, and it seems to be a great combination that works well for me. I completely new perspective on life. The things that I've gone through are most things that people don't go through until they're much older in life. So I feel like I've just grown so much as a person, spiritually, mentally, and yeah, I've got a fresh perspective, that's for sure. I think, well, we're all here right now spending time on the beach together, so I think everybody's really happy with the results. I'm able to play with the kids, and we're having a great time. The Immunocine team has kept very close contact with me through your nursing staff that follows up and checks in. I've also kept contact with Dr. Zago and Dr. Ellie and Dr. Halpert and Dr. Fairbear, anyone really, they're all willing to answer any questions you have and keep in close contact, which has been very encouraging, very refreshing experience that you don't get in some places. So it's been a great thing for us.
If you didn't get the Immunocine treatment, what do you think would have happened?
I think, I've always been a fan of what Albert Einstein said, right? The definition of insanity is doing the same thing over and over again, but expecting to get a different result. I think that if I would have continued to do what the traditional oncology playbook says, then I probably would have fallen right into that result. And I think that by trying a different approach, I have a potential for having a different result, and that has proven to be true in this case, is that my result is much different than most folks that are diagnosed with what I was. I've been, I guess, over 4 years now battling this thing, and whenever I came to Immunocine, it was really looking like a get your affairs in order kind of situation. So it's definitely contributed to where we're at today. Your mind and your spirit is half the battle, if not more. So we're really focused on that. We found something called freedom prayer that has really helped a lot. Kind of exchange a lot of that darkness for light, and that's helped a lot. And then also physically, we've adopted new supplements. We have a holistic doctor that helps us monitor a very robust panel of terrain metrics that we monitor, and yeah, we're trying to live a holistically well life. I really think it's the best first line of treatment. It really gets your immune system in the fight, and that's something that is, in my opinion, very absent today, because the immunotherapies, they're great and they rev your immune system up really high levels, but I think it would be much more effective if in traditional cancer care, they're training your immune system to recognize the problem first, kind of aim it at the target, and then rev it up so that it can really attack more efficiently. And I think it works well with anything, really, because you're effectively getting the immune system in the fight. So whether you elect to do chemotherapy like I did after the treatment, I think that it works great with that as well, just because for that simple fact that it is getting your immune system active in the fight. Every patient should research what pseudoprogression is. Pseudoprogression is a real thing that happens, and it's something that I think everyone should research before they come here, because it will help in that process you're in. After you get treatment, there's about 2-3 months where the pseudoprogression is a very real possibility. And if you know about that before coming here, I think it helps. Whenever you're given a diagnosis like this and you have all these things said to you, it can be really overwhelming. And I encourage folks to look outside of the box, because if you want a different result, you have to try a different approach. And one piece of advice I would give is make sure that there's an oncologist on staff whenever you're doing your research, because that really, I think, helps validate the treatment.
Done.
Hello everyone, and thank you for watching our coverage of Immunocine Cancer Center. Dr. Halpert and his team are bringing hope to millions of cancer patients around the world. I'm incredibly grateful to be in much better health and enjoying excellent quality of life after receiving my treatment. Immunocine has certainly blessed my family and I beyond belief. While the treatment is great, it's not covered by health insurance, and it costs about $120,000 for treatment, housing, and travels. This wouldn't have been possible for me if it weren't for the compassion of my community. In the middle of the COVID pandemic, our community pulled together and held fundraisers to cover my expenses. The compassion of our community inspired my wife and I to form the United Creed. The United Creed is an organization that is committed to helping people deal with this awful disease. We raise money for cancer patients to receive Immunocine dendritic cell treatments, and I encourage you, please visit our website at theunitedcreed.com and click the donate button and subscribe to giving $20 a month to our cause. That's only 65 cents a day, which isn't much, but your support is truly an answer to endless prayers. Without your support, our mission would not be possible. So thank you, and be golden.